Thank you so much for the opportunity to talk about my favorite subject, pregnancy and congenital heart disease. Um, we're going to give a whirlwind tour of the problem because it is something that we're all seeing, and it is impacting on maternal mortality, which is very problematic in this country. And so it's important that we understand it. In the old days, women were told just don't get pregnant, but that's not the case. These young women have grown up in a hospital and they want to be like everybody else. This is a great case to illustrate everything you really need to know about congenital heart disease and pregnancy. This was a woman who was born with tetralogy of Fallot. She had an initial palliation and then a definitive repair at age 5. Definitive repairs are now done during infancy, but subsequently she required a valve replacement in the pulmonic position and then a valvuloplasty of that valve, all as a child, and then she did well. And just to review tetralogy of Fallot, when the outflow tract is open and the pulmonary valve is open, so it could become stenotic or narrowed. The right ventricle is hypertrophied. There's a VSD which gets patched so that the aorta is over the left ventricle, and that is the primary repair that is now being done. Now, this woman came to me in her first pregnancy, and we had increasing pulmonary pressures, which could be just due to the pregnancy alone, but it turned out that it was branch pulmonary stenosis, which is a common problem in this patient population. This she underwent stenting, and then soon after she became pregnant while on aspirin, and during that pregnancy she developed endocarditis, which is a risk in this patient population, pregnant or not. And she was treated with antibiotics. The lesson being is that you do not withhold any care that is appropriate for a pregnant woman. You just pick the safest options. Then after she delivered, we had to replace the valve because of the stenosis and the calcification of the valve, and therefore her third pregnancy was uncomplicated. It's interesting to note that in her fourth pregnancy, she decided she had had all the problems and she delivered at home and was lost to follow-up, which is a problem in this patient, and that's why many cardiologists or obstetrician gynecologists see these patients when they're already pregnant. To review the hemodynamic changes of pregnancy, we have an increase in cardiac output that occurs to support two circulations. Most of that is done by blood volume. And you can see when these increases start. They start in the second trimester and then kind of level off. The important thing in a woman with heart disease is really the postpartum period, because she has to get rid of all that fluid. And so that certainly needs to be considered in our management. Some of the things we worry about is just bottom line, morbidity, mortality. How do these hemodynamic effects affect a woman who has heart disease, especially valvular heart disease? The pregnancy may increase the risk of arrhythmias in a population already at risk. If they do not have optimal systemic ventricular function, they could develop heart failure. If there are shunts, or prosthetic material, there could be an increased risk of thromboembolic events because pregnant women are hypercoagulable. Pulmonary hypertension may increase, and it is a contraindication to pregnancy. And then aortic dilatation in women with coarctation. Turner syndrome, the aorta may dilate during pregnancy and then become complicated with dissection or rupture. Medications need to be evaluated and changed to medications that are more compatible with pregnancy. There are many signs during pregnancy that that may denote heart disease, but can be normal in pregnancy. So it's important to really evaluate them within the context they occur. We can do any EKG-based studies. Echo is pretty much our workhorse during pregnancy. We can do stress testing, sometimes with heart rate limitation, cardiac catheterization if it is indicated, but we avoid nuclear studies because the isotopes concentrate in the bladder. Echocardiography is particularly useful because it can be done serially, it's non-invasive, but there's some caveats. It may overestimate the pulmonary pressure and it may overestimate valve gradients. So it's important to, again, look at the entire context. Transesophageal echocardiogram can be done during pregnancy if it is clinically indicated and will alter your outcome. This is an example of a fetal echo. So all women with congenital heart disease, and parenthetically, the partners of men with congenital heart disease should have a fetal echo because they have an increased risk of congenital heart disease in their offspring of about 4 to 10%. And this should be done by a pediatric cardiologist at about 22 weeks. It may have to be done again because they may not be able to see all of the parts of the developing heart. Management during pregnancy, again, takes into account the woman's problem. We wanted certain medications are better than others. For example, diuretics are only used with heart failure or pulmonary edema and not prophylactically. Beta blockers, we tend to use the selective agents such as metoprolol. Our vasodilator of choice tends to be hydralazine because we cannot use ACE and ARBs during pregnancy because of fetal complications. Digoxin is helpful with arrhythmias, particularly supraventricular arrhythmias, because unlike a beta blocker, it does not affect the blood pressure, and oftentimes women have low blood pressure during pregnancy. Just a quick view of some of the lesions and what to anticipate. An atrial septal defect, if it's unrepaired, carries a risk of paradoxical emboli, and again, we're dealing with a hypercoagulable patient. Anybody who's either has an unrepaired or a repaired ASD is at risk for arrhythmia. A ventricular septal defect is different. This is a high-risk lesion for endocarditis if it is unrepaired. If it has been repaired, there can be elevated pulmonary pressures, and there can be residual shunting. So those are some things just to think about. And AV septal defect, which would include your endocardial cushion defect, primum atrial septal defects. Those are usually fixed with a patch here, but because it's a lot of surgery, they're at risk for heart block and or other arrhythmias. They could have residual shunting through that patch, and oftentimes this is associated with a cleft mitral valve, and they may have significant mitral regurgitation and when they present as an adult. Coarctation of the aorta is usually diagnosed in childhood, but we've had several adults in whom it was diagnosed during pregnancy. Often these patients present with hypertension, and it is one of the secondary causes of hypertension. It's often associated with a bicuspid aortic valve, and even if the coarctation, which was over here, which was fixed either surgically or with a stent in childhood, it can re-narrow in adulthood. And in pregnancy, even if the area of the coarctation is patent, women still can have hypertension. It is also associated with a bicuspid aortic valve and all of its attendant problems, such as aortic insufficiency or aortic regurgitation or aortic stenosis and aortic dilatation. It's particularly there's a particularly high risk in the woman with Turner's. Ebstein's anomaly is usually detected in childhood, but the main point is that you've got this atrialization of the right ventricle, so you have a small right ventricle, and you can have an atrial septal defect, and if mom is cyanotic, there's an increased risk of low birth weight and fetal loss. The study did show that the risk of congenital heart disease in the offspring was about 6%. The last lesion I want to talk about is transposition of the great vessels, where the great vessels are literally transposed. So the aorta comes off the right ventricle and the pulmonary artery comes off the left ventricle. In the olden days, what they did is they reversed the incoming flow. So they took the venous flow and got it over to the left ventricle out to the pulmonary artery. The systemic venous flow, the pulmonary venous flow, and it was diverted to the right ventricle and out the aorta. Problem being is that you're asking this right ventricle to be a systemic ventricle during life. Same thing with the L transposition or the congenitally corrected transposition. The newer operation takes these two great vessels and switches them. That's called an arterial switch. And that has its problems too in the adult population, but it makes a lot more sense, and then you have a systemic ventricle. The most important bottom line with this patient population is doing preconception evaluation so that you can talk to them, find out what surgeries they have, what are the sequelae of surgery. Do they need an intervention before they have a pregnancy? Are there medications safe for pregnancy? What is their functional capacity like? So you have a very complex patient like with a detransposition mustard who has a systemic right ventricle, but if she can run a marathon, she could probably get through a pregnancy. But that's not enough. You have to do objective testing. So you look for arrhythmias. We do a lot of stress testing to look at the integrity of the right ventricle and the left ventricle, because that's the important thing in pregnancy. MR imaging is important to look at aorta, and if necessary, cardiac catheterization, certainly to make the diagnosis of pulmonary hypertension, which you do want to find out before somebody gets pregnant. In conclusion, Pregnancy in women with congenital heart disease is a multi-specialty event. We're all in the same boat as depicted in this Korean painting, where the pregnant mom's in the middle and anesthesia is involved and high-risk OB and her general obstetrician. Everybody needs to be on board and understand the special considerations that could arise in this patient so that she can have a safe pregnancy for her and her baby. Thank you so much for your attention.